This will be the last of the three of our talks on newborn GI disorders. We're going to talk about Hirschsprung's neck and imperforate anus, which are obviously three very different disorders. So Hirschsprung's disease is an absence of ganglion cells in a segment of the colon. It tends to be in the rectosigmoidal area, 80% of cases, and from there it can extend proximally, so it can go further up. 15 to 20% of cases will extend proximal to the sigmoid, and less than 5% will involve the entire colon. So most cases just involve the rectosigmoid, but what I want you to get out of this is that they affect, even though segmental Hirschsprung's has been possibly described in the literature, the way this works for the most part is that you have disease in the rectum, and it can go further than that, further proximally, but it always involves the very distal colon. So you might have it in the rectum, you might have it in the rectum and in the sigmoid, you might have it in the rectum, the sigmoid, and the left colon, you might have it in the rectum, the sigmoid, the left colon, and the transverse colon, but you would very rarely, if ever, have it in the transverse colon and the sigmoid and in the distal rectum. It doesn't skip around. So it starts distally and it can affect more proximally as well. Okay, that having been said, this is not a rare disease. It occurs in 1 in 5,000 babies with a predominance in boys 4-to-1, similar to that predominance that you see in hypertrophic pyloric stenosis. And it is also associated with genetic anomalies, particularly Down syndrome. So the way this presents in neonates is a failure to pass meconium, vomiting, abdominal distension, reluctance to feed. If it's not diagnosed in time, it can also lead to enterocolitis as well. The classic way this is described on physical examination, although you might not get this on physical examination, but the way the boards loves to throw this at you is that you do a digital rectal exam and you don't, the rectal vault is empty. But when you pull your finger out of the rectum, there's a gush of stool and flatus. And the reason that would happen is because, let's say you're pushing your finger in through the rectum, you cross the aganglionic portion, and then you pull your finger out. What you do when you're pulling your finger out is you're dilating that aganglionic portion. And the fact that that portion can't dilate is the problem in Hirschsprung's disease. So when you dilate it, all the pressure that's proximal to all the meconium or stool contents is going to push that straight out of the colon, and so it's going to come right out onto the exam table. So this is classically the way it's described on physical exam, but you may not see that. It comes up a little bit different in children, but for the most part, this is going to be GI problems, particularly related to constipation or failure to pass meconium. For diagnosis, the best initial test, like any baby with failure to pass meconium or abdominal distension, is going to be to get to get an X-ray initially. That X-ray will help you determine the nature of the obstruction, and what you will see with Hirschsprung's disease typically on X-ray is multiple dilated loops of small bowel. That tells you you've got a more distal obstruction. You'll then follow this by contrast enema, and that contrast enema usually shows us a transition zone. Not all neonates will show that transition zone, and so I want to be clear about that. The absence of a transition zone in neonates is not, it does not rule out Hirschsprung's disease. So that's important to remember. So other tests that can be done to rule in Hirschsprung's disease or to diagnose it are anorectal manometry, in which case you're looking at the muscular tone of the rectum, and then the most accurate test is a rectal biopsy. But we like to do anorectal manometry first because that is you can get your results right away. Whereas with rectal biopsy, you need to put the baby in to an OR, have a surgeon take a biopsy, and then send that off to a pathologist, and that takes time. So the anorectal manometry is really a good tool in your diagnostic toolbox for looking for possible causes of failure to pass meconium in general, and that also has to do with the fact that Hirschsprung's disease can overlap with a lot of other GI disorders, particularly the meconium plug syndrome. So here's Hirschsprung's disease. Here you've got your abnormal aganglionic portion. This portion cannot relax, and so everything is obstructed up to there. And there's another one. There you go. Okay, so to manage this, you're going to get pediatric surgery on board. They'll probably want you to get a rectal biopsy just so you can hammer down that this is 100% Hirschsprung's disease. And then they're going to resect the aganglionic portion. They do it a little bit differently if it's a child or neonate or infant. So that's really at the call of the surgeon. You don't have to worry about that. Complications from there are pretty much fecal retention or incontinence. That's going to be any time you operate on the rectum. And then anytime you're sewing together two pieces of lumen, you can have an anastomotic breakdown, and you can also get stricture and general surgical complications. Necrotizing enterocolitis is typically going to be your premature baby who was discharged and is home and doing okay, and now mom and dad bring baby in because the baby's belly is distended and the baby won't eat and the baby had blood in their diaper. And that's the classic way necrotizing enterocolitis comes up. When you look at your vignettes on the test, look for a premature baby. If it's not a premature baby, necrotizing enterocolitis becomes a little bit less likely. But premature babies are the ones that typically come in with this. I mean, in real life, never rule out necrotizing enterocolitis just based on the fact it's a premature baby or not a premature baby. But on the USMLE, they will classically throw this at you as a premature baby. Why does necrotizing enterocolitis happen? We don't really know. But what I've read and what I find to be the most persuasive is that there's bacterial discolonization of the bowel. And by discolonization, I mean that you have bacteria in the flora that really aren't supposed to be there. And so they can cause infection, and that infection can then cause hypoxia, and that hypoxia causes sloughing, and then you can get invasion into the wall, and that's going to be what then causes your gangrene and perforation. Also, that invasion into the wall will be what will also show your pneumatosis intestinalis, which is sort of your key feature that you'll see on X-ray. So again, like I said, the symptoms here, it's a premature baby with abdominal distension, belly pain, and bloody stool. Other symptoms can be the baby doesn't want to eat, baby's vomiting, diarrhea, decreased bowel sounds, or very ominously, erythema over the abdomen or shock, which is going to require immediate surgery. Initial labs, of course, are going to be useful to start out with. CBC classically will show a thrombocytopenia, but that doesn't necessarily need to be there. An abnormal white count, but again, that doesn't have to be there. The way this usually works is in necrotizing enterocolitis, baby's white count will be high, and then it will come down. And usually when the baby's really sick, the baby's actually going to have a leukopenia. So if you catch the baby in the middle of that, the baby's white count will be normal. And so you can't really rely on the white count for helping you diagnose this. And then a low hematocrit. The BMP will often show a low sodium and often a metabolic acidosis. You should also get blood gases because we're concerned about the acidosis. Number one, best initial diagnostic step is an abdominal x-ray. If you are suspecting necrotizing enterocolitis, which you always should in a premature baby who has abdominal distension after discharge, coming back into the hospital with abdominal distension, get an x-ray. Neck is deadly, and if you if you diagnose it in time, you can save the baby's life. So you get an abdominal x-ray, and typically this will show dilated bowel, very edematous, swollen walls, and then the very classic sign that I imagine will come up, you get a picture of this on the test, is intramural air, or also known as pneumatosis intestinalis. And this is not pathognomonic, but it's virtually pathognomonic for necrotizing enterocolitis, particularly if you've got the baby that fits all the clinical criteria. Definitely be observant for signs of bowel perforation, because perforation is an absolute indication for emergent surgery. We don't, as you're going to see, for treatment, we try to not do surgery on these babies. But if we have to, if there's perforation, then we will. But it's generally the rule of thumb with neck is if all else fails, or if the baby gets perforation, then we do surgery. When you get the x-ray, and this is another important thing, if you're suspecting neck, you're taking step 3, you need to make sure you remember this, that with necrotizing enterocolitis, when you're getting an x-ray, if you suspect necrotizing enterocolitis, you've got a premature baby, abdominal pain, and bloody stool, and bloated, you need to get an x-ray both in your AP view, and that'll help you look for the pneumatosis intestinalis, look at your edematous walls and everything, but also in a left lateral decubitus view. The reason for that is because you are also looking for perforation, because if there is perforation there, baby is going to surgery lickety-split. But if there isn't perforation, then you can be a little bit more conservative. So you're going to be looking for air, and the place you look for that is over the liver. That's a good place to look for it. Okay, so here's an x-ray of necrotizing enterocolitis, obviously an AP x-ray, and your pneumatosis intestinalis is right here. You can see air in between the layers of the intestinal wall. Just in general, also, you see very thickened lumen walls, too. So again here, see the separation between these walls and the outer part of the lumen? This is pneumatosis intestinalis. Okay, and then this is a perforation. So see here, you've got free air. Okay, how do we manage this? Assuming that baby does not have a perforation or doesn't have any of these signs of decompensation, so that would be evidence of perforation on x-ray, fixed dilated loop of bowel, which you wouldn't see initially, abdominal cellulitis, which would be redness over the belly, and then deterioration despite maximal medical support. So the only way these two, you would do immediate surgery as soon as the baby comes in, would be if you see perforation on x-ray or abdominal cellulitis. Assuming the baby doesn't have that, then the first thing you're going to do, of course, is let pediatric surgery know. Then the baby is going to be absolutely NPO. So baby doesn't take anything by mouth, because that will exacerbate the situation. You'll want to do NG decompression to get anything that's in there out. Then baby will be put on supplemental oxygen, and you'll also closely monitor the pulse ox, because any compromise in the pulse ox shows a compromise in the necrotizing enterocolitis. Baby will be on IV fluids and total parenteral nutrition, because you've got NPO, and then broad spectrum antibiotics, and this is going to be how we're going to try to treat this without doing surgery. So ampicillin, gentamicin, piperacillin, tazobactam, just make sure it's broad spectrum. And then you'll do repeat x-rays to look for improvement in baby's condition. You also get repeat blood gases. That's useful as well. You want to make sure that baby's not going into a metabolic acidosis, and if they are there, that it's improving. Like I said, immediate surgery, if there's any evidence of perforation on x-ray, remember you're getting AP x-rays and left lateral decubitus x-rays. If there's a loop of bowel that just will not, that's just not healing, then you can do surgery then. If there's abdominal cellulitis at any point, you do surgery then. Or if there's deterioration despite maximal medical support. You do not resume PO feeds until the disease resolves, both in the baby's symptoms and on X-ray. All right, so we'll finish up with the imperforate anus. This is an abnormal termination of the anorectum, and you don't really need to know a whole lot of this. The USMLE won't expect you to know a whole lot of this, at least, other than that there's an association with bacterial, which is vertebral, anal, cardiac, tracheoesophageal fistula, renal, and limb. And then also that it can be a cause of failure to pass meconium, but the thing is, typically this is discovered before we expect the baby to pass meconium. You're doing your nursery examination usually within 6-7 hours of birth at the most. So typically you'll see the imperforate anus before we get worried that the baby's not passing meconium. So with the imperforate anus, you can also get fistulas, and that can lead to problems. So with girls, it can fistulize into the vaginal vault or into the perineum. With boys, it can actually fistulize into the urethra. So that can be really problematic. But in some cases, it's just a blind rectum. For diagnosis, you can just diagnose this on physical exam, but you can also get a urinalysis or pelvic radiographs if you want to. The treatment is surgical repair. So there is no anal opening here. This is an imperforate anus. What I really want you, though, to remember is that these babies need a workup for other congenital defects, particularly in the heart. So because these babies are going to be getting surgery, you'll have them on NPO. You'll get them IV fluids and nutrition parenterally, and then get an echocardiogram to rule out any cardiac defects, and then surgical correction. And there's so many different ways that the surgeon can do this. You don't need to know any of those. So, failure to pass meconium. This is a common problem on the USMLE. It's something neonatologists deal with all the time. The hallmarks of neonatal bowel obstruction include failure to pass meconium in 24 hours, abdominal distension, reluctance to feed because of the distension, and bilious vomiting. So what do you do in a neonatal bowel obstruction? The first thing you do is, of course, look at the baby, rule out imperforate anus, anything that may be blatantly obvious. Number 2, you are going to order an abdominal x-ray. This is a very easy thing to do, and you can diagnose some things just by an x-ray alone. So a double bubble sign will show you duodenal atresia or malrotation. It can also show you multiple dilated loops of small bowel, which signify a lower intestinal obstruction. So this will help you kind of get an idea of where the problem is at. Next thing to do is order an upper GI series. So an upper GI series can help you, and you don't necessarily need to do this with the upper GI series, but I think it's helpful because it helps you look for some of those more upper things. A lot of people might just go on to a lower GI series, and that's fine too. But an upper GI series will certainly help you with diagnosing malrotation. In that case, you'll see a duodenal loop that doesn't cross the midline. It can also help you diagnose malrotation with volvulus, and you'll see that bird's beak sign. And then it can also show you a jejunal or ileal atresia, in which you'll see a transition zone in the small bowel. Of course, a lower GI contrast enema, if you see a total microcolon with insipated pieces of meconium, that points to meconium ileus. If there's filling defects in the large bowel, that shows you that there's functional immaturity and plugs of meconium. That's meconium plug syndrome. If there's a transition zone in the rectum, Hirschsprung's disease. But remember, lack of transition zone does not rule out Hirschsprung's. And then finally, another thing you can do is rectal manometry. So these are the things that you have in along with looking at babies' physical exam, symptoms, any labs. These are the things that are going to help you determine why the baby has failure to pass meconium, why the baby has a bowel obstruction. And so with these 4 tests, you should be able to come to a conclusion. And if you have any other questions, if I didn't explain anything completely, please feel free to make me aware.